Good afternoon, and thanks for joining us today. It's good to look at all your faces, okay, and see that you're healthy, okay? We'll be together here for about 30 minutes or so. This is President Eva Germain Shimotakehara with the Coos Bay North Bend Rotary, and I have Diego right beside me. Diego, come on in here beside me. Until our club board decides to resume weekly meetings in some alternative format during this COVID-19 stay-at-home period, I plan on scheduling periodic online opportunities for our members to hear messages about important topics from local speakers. Today, we're fortunate to hear from Brian Moore, administrator of Bay Area Hospital and a member of our club. Before I turn the floor over, I have a couple of housekeeping items about Zoom. Today's meeting is being recorded, and it will be shared as a public health benefit for the community and for other nearby Rotary clubs. A copy of the recording will be emailed to all of our club members. Past District Governor Bill Greil is running the controls for today's online meeting. To preserve bandwidth, we will be muting everyone except the speakers at the beginning. If you can locate the toolbar at the bottom of your Zoom screen, you'll see a list of today's attendees under participants, and next to your name, you can hit that icon and you can see the opportunity to raise your hand. If you can't do that, just put your hand up and Bill will see you, okay? Please feel free to do that if you have a question. There will hopefully be time for questions after Brian concludes his message and everyone will be unmuted. If we run out of time and you have a question or a comment, please go ahead and email it to me and I'll get it to Brian. So is Brian on here yet?
Eva, I'm not sure. So what I'm going to do is I'm going to unmute everybody, but
Okay.
If everybody starts talking at the same time, it gets very confusing. Okay. So I'll just unmute everyone and Stephen can take the floor. Stephen Shimo.
Okay.
Brian there?
I don't see him yet, but we can do a few things here. Diego got his iPad that the Rotary bought for him. So he used to have this tiny little iPhone 7 phone doing all his work on. Now he's got this. So he wants to say thank you here.
Thank you to the counselor for me.
So Diego is from Spain, and his father is there alone with an exchange student from Taiwan. Right. The exchange student from Taiwan was going to go back to Taiwan, but didn't because he couldn't get a flight out. So his dad is there with him. And I see Brian is here. Brian and Lindsay is here. Stephen, take over. Stephen Shimotakehara?
Yeah, can you hear me?
Yes, could you introduce Brian?
Yeah, it gives me great pleasure to introduce our fellow Rotarian, Brian Moore, who is the CEO of Bay Area Hospital, which will become the focal point response to COVID-19. And it's amazing. I think he's only been our CEO for the last year, but during that time, he's been a dynamic, inspirational, and very effective leader. And we're very pleased to have him here to talk to us about the hospital response to COVID-19.
Okay, Brian, you can go ahead. We're gonna mute everybody while you speak. Okay.
Great. Well, let me tell you a little bit about what it has been like from a Bay Area hospital perspective. And I'll kind of just actually run you through a little bit of the chronology as we've stepped up our preparedness. And then I'm happy to answer some questions at the end. So March 2nd, actually, just before the state's formal declaration of a state of emergency, we made the decision to stand up our incident command structure at the hospital. For those of you who may not be aware, there is an incident command structure that exists across the country. FEMA actually puts out some standardized training modules and classes. And if you're at a hospital or if you're at police or fire or Office of State Emergency Preparedness or Management, we all utilize the same incident command structure. So that system is really flexible. You can deploy it in size and scope based on the particular event that may be presenting itself. So we split up our incident command it's nice because we use the same job titles and descriptions, across all these different agencies, and it makes it much easier to coordinate resources. So we activated a number of different sections. Initially, operations, logistics, finance, public information officer, liaison officer, incident commander. And then we brought in some technical specialists. For us at the beginning of this outset, it was our infection preventionist. And then we also activated our safety officer. And so we began meeting on a daily basis, and that has continued, weekends included, since we stood that up at the beginning of March. And the initial focus is one that continues to occupy an undue amount of time, and that is discussion around personal protective equipment. It is amazing to think that the world is unprepared to deal with this COVID-19 bug, and one of our basic weapons of protection equipment for staff at a hospital or frontline personnel is just beyond limited. And so for the first couple of weeks, there were changing guidelines from the CDC, from the World Health Organization. We actually are tuned in most closely to our local Oregon Health Authority, whose guidelines have differed or aligned based on the particular day. And they seem to change during those first couple of weeks by the hour. Sometimes literally we'd meet in the morning and we'd take in the new information and begin transferring that to our regional plans. And by later that afternoon, there would be new guidance about how PPE should be used or prepared or distributed. And so just a tremendous amount of effort. We centralized our supplies of PPE at the hospital. So PPE for us is a couple of different things. There's two types of masks. You might hear it called a flu mask or maybe a surgical mask. This is just a basic mask. It's not a high quality filter mask. In fact, we call those N95 respirators. And that's what you would use where we're concerned about airborne contamination or cross-contamination. We're short on both of those. The other component is a face shield. That can either be goggles that seal tightly to your face or a face shield that would wrap around the sides and really cover your entire face. And of course, it's gloves and it's gowns for us. So that's the recommended PPE. And we have two different levels of use guidelines, and for many of those we're in crisis use, which is looking at how we maximize our supply and extending the use. In conventional use, we might tell staff to don a mask, and literally every time as they're in and out with the same patient, they would throw it in the trash. Today in crisis mitigation, we might ask a staff member to be assigned a mask and to use that mask for the duration of the day. And so, that's been the journey here, and we're in lockstep with hospitals across the country. So making sure that we have PPE, it has been and is an ongoing focus, but that's certainly where we started. We've been managing off of really three objectives. The first one is remain open for care as an organization. The second goal has been to protect our employees, our physicians, and our patients. And our third goal has been to develop and maintain a single source of communication. They sound pretty simple. They're hard to execute consistently as we've gone through. So the hospital has emergency plans, and as we begin to learn more about COVID-19, we have adapted and really continue to adapt our hospital surge plans. So first was thinking about how we would grow and perhaps segregate a flood of patients as they would show up at the emergency department. You may have seen an article last week. We deployed our tent. Plans are currently that we would use that probably as a separate intake area, perhaps cohorting patients with respiratory symptoms out in the tent and keeping them separate from patients in the rest of the hospital and in the typical emergency waiting room. Rooms have negative pressure relative to the hallway or any adjacent rooms. And so the plan was we would bring patients in and we would put them throughout these 19 negative isolation rooms as the hospital. Really, we quickly learned that these patients were likely to present with very significant ICU critical care needs. And the idea of having them scattered for our airborne precautions really wasn't going to work. So plans turned to capabilities that we can deploy mobile isolation units and convert existing rooms into negative flow. And we could cohort those, put them all together and have one negative isolation unit really adjacent to our existing intensive care unit. Then the guidance changed and no longer was airborne precaution required, except when we were doing particular procedures. And so then we went back through and adjusted our surge plans on the inpatient side now, as we had already adjusted our emergency department plans. So we've got plans where we would fill up first our existing intensive care unit, and then we would grow to an adjacent unit, and then how we would take our step down unit and displace typical lower acuity, what we might call medical surgical beds on the hospital. And at that point, how we would begin to separate COVID patients from non-COVID patients, and how we would grow our capacity to meet the surge. So, those are all planning activities. And as we've learned more about this, as the guidance has changed, last week, we've really begun to solidify and engage our regional partners. So hospital CEOs first met with chief nursing officers, chief medical officers, to really begin the dialogue on how could we better operate and coordinate as a region. And the chief nursing officers are working to put together a draft and then with our medical staff to talk about how patients would be shared across our regional assets. There seems to be a strong interest from the critical access hospitals down in Gold Beach, Curry General, in Bandon, Southern Coos, in Coquille Valley Hospital, and then in Reedsport may have some interest as well with Lower Umpqua, all participating as a region here and setting up a process as to how we would intake patients and really share our resources. They may have ventilators that they could move to the hospital. And we would look at moving lower acuity patients back to their environments. There's a little bit of update. I'll talk just briefly about coordination on the communication front. So our public information officer and liaison officers have been very involved. Probably 6 weeks ago, public health had been convening a group that had really been 10 to 12 people participating. And about a month ago, that mushroomed, and now they're meeting twice a week with probably 50 to 60 participants in hand. We have increased our participation and communication with our local clinics, North Bend Medical Center and Bay Clinic, and have had ongoing communication with them over the last month, again, as this scenario has changed. So that has been a regional resource coordination. Most recently, we're coordinating public health, looking at some assets in the community. And we toured the Baycrest site, thinking about how that might be utilized in a true community surge situation, and how we could reactivate that facility to handle some overflow that may be not appropriate, may not have hospital level needs, but still may not be appropriate to go back to home, or where we may be shut off from some of the other post-acute care settings. We've seen how devastating this illness can be if it gets into a retirement home or a skilled nursing facility. That's just a very vulnerable population. And so patients that we normally discharge back to those settings, over the last several weeks, we've had very limited opportunities at points to get patients into those facilities. And that means we don't have a bed available in the hospital for a more acute patient. Anyway, so we had a chance to tour the Baycrest site. it's been inactive for over a year. It has some infrastructure needs. And so we're working with community partners now to understand how we can put together a scope definition of what it would take to turn that facility back into one that could care for people again, and then how it would be deployed in a potential surge scenario. At the regional level or the state level, through the Hospital Association, CEOs have been on a call twice a week. And so it's been very helpful to have that forum. We have had a lot of input through that group into the governor's office and into the Oregon Health Authority as they're putting forth guidelines. And so it's been a very effective way to channel our information. One of the things that you've seen come out of that, I think, is a prioritization on getting childcare availability for healthcare workers. You know, we were very concerned that as the schools closed, we would lose access, to a significant portion of our workforce due to childcare concerns. And so that's one where I feel like we've had effective partnering going on with state agencies. More recently, we're working through funding. You know, many of our rural healthcare settings are facing very significant financial challenges. The governor's order to postpone elective procedures with the goal of preserving those face masks and that personal protective equipment has had a significant financial impact to the healthcare sector across the state. And, you know, it's really sort of ironic that we're facing this huge pandemic and we're in this lull before a surge that we hope never happens in our community, but we're in the process of sending healthcare providers home. We saw the clinics make significant adjustments, very difficult decisions with their clinical practices, balancing that desire to serve the public with the realities of how to protect the public. And we find ourselves in the hospital sector doing the same thing and navigating that. These healthcare workers that got sent home or we're sending home on a daily basis because at the hospital our volumes are down at this point are the same healthcare workers that if we see a surge, the one that we hope doesn't happen in our community, we'd be calling back to work and hoping that they would be available to help us out. So there's this dichotomy and tension of where we sit right now as we try to manage through COVID-19 and take advantage of this time to fully prepare. So the hospital has enjoyed some tremendous support from the community. We've had the donations being brought in of cloth masks being sewn, and spent some time this last week talking about how we integrate those into our process at the hospital right now. And you know, it's been great to see the community rise to support healthcare workers, not just here, but really across the state. I think sewing machines are active in many communities, sewing these new protective equipments. And last week, there's been a shift now, not just to make masks, but also to get protective gowns, which are in short supply. We were actually able to buy some reusable gowns. I think we got 300 reusable gowns in, and we're laundering those now. And folks in the community are also sewing some additional reusable gowns. We have a laundry on site at Bay Area Hospital, and so we're able to, you know, launder those protective gowns and get them back out the next day, which is, you know, a real godsend when our typical supply, you just can't be dependent on. Our supply chain folks are combing, you know, to find any avenue, legitimate avenue. And that's the other thing that we kind of have to have our fraud sensors up because as sad as it is, you know, there's a segment of folks out there who will take advantage of this panic and sell something they don't have and take your very real dollars and give you nothing but a hollow promise in return. And so trying to sort through the legitimate sources of help from those who are not, when you're dealing with international companies and people who are calling you and unvetted sources is also a real challenge. We're also wanting to not miss an opportunity to secure legitimately additional PPE items so that we've got the right amount of protective equipment for our employees, our physicians, and our patients going forward. So that's something that we spent time just earlier today, trying to navigate who's who and who can be trusted and how much PPE can we get our hands on. So I'll stop there and maybe answer a few questions. We can probably unmute the lines, or folks can unmute them individually. I would say that we're even better prepared now, several weeks in, than we would have been had we walked straight into a flood. And we're taking advantage of each day that we have to learn more about what we might expect and to strengthen our partnership with organizations across the region here, and to do more to strengthen our planning. We have a significant resource in terms of Bay Area Hospital, and we're looking at how it can really serve not just Coos Bay and North Bend, but be used to support the whole South Coast region.
Thank you, Brian. We have a number of people who are only on their phones. So the people we can see can put up their hands and say who they are. And the ones on the phones will have to say their name and say they want to ask a question. So go ahead, anybody who wants to ask a question. Put your hand up. No questions? There's one from David Bassett. David?
Brian, thank you for the discussion about joining forces with the other hospitals. I've been aware that the hospital in Gold Beach is having a significant financial problem. My question, I guess, is assuming that the flood comes from the south and hits Brookings first, where should people go first? Should they go to Sutter or Gold Beach or Bandon or straight to Coos Bay?
Great. So Virginia Williams, the CEO from Curry General, was on we did where everything's virtual, right? We did a WebEx meeting. So she was on the meeting with us. Her chief nursing officer was participating on the call yesterday with the regional planning. There's so many variables in there that it's hard for me to counsel universally that someone would bypass their local healthcare system. I think, if it's a true emergency, that's still the best scenario to start with. And I would trust those local organizations to develop the connections. What I can say is that from a Bay Area hospital perspective, Gold Beach, we're in dialogue and we're actively building our plans together so that we've got, a clear way for coordinated patient care.
Thank you.
Other question? Deanne?
Can you hear me?
Yes.
Yes.
How about those nurses and doctors that are semi or retired? Are you taking a list of those people in the community that you could call on if you needed their services?
Yeah, so one of the things that we did probably a couple weeks into this was formally stand up a planning branch. So we're about, 2.5 weeks now into having a formal planning branch. And we have a medical staff group within that planning branch. It's really been working on a couple of things. And one of them has been to look at putting together and filter all of the different science that is changing. What's the best approach to teaching these, taking care of these patients, and then beginning to look at how do we put some education components around that. I know I had some opportunity to dialogue with the clinics around some of their staff that would be going home, and our group is at the hospital still working through what is that gap perhaps for somebody who hasn't been in an acute care setting, to get them comfortable to come into an acute care setting where we might experience a patient surge. So nurses to come in who haven't been in the hospital setting, how would we train them? In talking with public health, I still have a connection to make with the Southwest Workforce Investment Board. I may not have that directly, but they may have some additional resources that could assist in that training effort. We may even have some access to training resources from the college that might be able to help with that, as the more traditional routine healthcare has been postponed, and we support the redeployment of that in a surge situation. You know, definitely we know that this COVID-19 impacts older folks, particularly who may have an underlying health condition with greater devastation. And so, you know, bringing back a retired workforce who may be in that category, we made the difficult decision probably 2 or 3 weeks ago now to really suspend our volunteers who were greater than 65 years old from coming to the hospital. Again, just trying to provide that social distance and keep early to Bay Area Hospital. So there may be some additional ventilators in the community that could come to Bay Area Hospital and be of assistance. We also have really some items that are intended for very short term ventilation support. They're called transport ventilators. And don't think highly sophisticated electronics here. Think something that you open a disposable plastic package and hook it up to oxygen, and it kind of runs a compression and vacuum cycle and would replace manually bagging a patient. That could still be better than nothing, and we do have 85 of those transport devices in-house. So that's kind of where we sit on the ventilator front right now.
Nettie, you have a question?
Who? Yeah, this is Joe. Brian, couple things. First of all, I'm on the workforce board, and we can help you with the training, and we do have some dollars for that.
Thank
Second,
you.
we also have a source for the P95 masks, so you might want to talk to Kyle about that. I know they've ordered some. My other question is, has the North Bend Medical Center closing put pressure, or could put pressure on Bay Area Hospital in responding to this virus?
Yeah, so we've had good coordination. You know, there were some concerns, you know, the day that it happened, we need to discharge somebody, who's going to be there for follow-up, what about medication? And I think we were able to quickly resolve those in our dialogue with North Bend. You know, they have invested considerable to try to expand their ICC. I don't think that we've seen an undue surge of patients through our emergency department. So I would say, you know, right now it seems to be working, and, you know, we've got the mutual commitment to just stay in tight dialogue and work through this together.
Okay.
Other questions?
I'll talk later. I don't.
I got another follow-up, if you don't mind.
Sure.
So, Brian, isn't there any government assistance to help you with these employees, especially the ones that you've had to temporarily lay off, you know, during this downturn, so we can still have them on board? Is there any financial assistance available?
So, you know, the CARES Act was just passed. We actually have a call later this afternoon with one of our attorneys to help us process that. So, in the preview to that call, you know, he said some interesting things about. I think we may have all seen some of those salary dollars and the assistance for folks who are laid off, the unemployment benefits being extended and amped up. Those may not be available to Bay Area Hospital because we are a governmental entity. And so that's something that we need to get the attorney to help us understand, you know, the digested version of what's available to help. I can tell you that through the Hospital Association, there's been a strong focus on requesting that the state get some quick dollars out there for rural healthcare. Bay Area Hospital, from a cash management position, sits much better than some of the smaller rural hospitals, even those in our South Coast region. And so, you know, there are recommendations going forward that the state allocates some pretty significant cash management support resources for dollars. So Joe, you're exactly right. There's a lot of things that are going on out there from a state and federal government perspective, and we're trying to wrap our arms around what's available to, actually help us, help our employees, and help us be here for the community as strong as we want to be.
We only have a few minutes left. We're going to get cut off. We have 40 minutes. So I just want to ask one more thing of you. When this really gets going, if and when it gets going, and we do have a lot of COVID cases, the mental health status of the medical personnel is going to be very difficult. How can we help them both physically, because it's going to be a drain on their bodies, and mentally? What the ideas and what we can do then?
Yeah, so we do have some crisis management skill sets and debriefing in terms of personnel at the hospital who can help. I can tell you that we're checking in with our teams. How you doing? Encouraging folks to take care of themselves. This is a long duration. We're already a month into this at a pretty brisk pace. And certainly there's the risk that we get run down and we get sick. And then, of course, we don't know any good. There's the financial strain that everybody's going through that compounds the fight against COVID-19. And so I think that we're going to have to continue to have the dialogue with our medical staff, with our nurses, with our team at the hospital. And that's something that we need to do across the community in terms of supporting one another through the ups and downs of this whole process.
Thank you so much, Brian. We're probably going to need to give you food too when that happens. Probably going to need to deliver food. I think we're nearly done here. Diego is wearing a mask, shield that we're making. Can see this?
Oh, I see it now. Yeah, I see it.
Kind of hard to see, but we're making.
Disappearing Diego.
Yeah, right. Disappearing Diego. Right.
Yes.
What they really disappear, don't they? Wow.
Yeah.
Wow. Okay. So it's number 20 gauge marine plastic with Gorilla Tape and the wrapping that you put around pipes in the winter. So it's working. It will work.
That's great.
I think, where are you, Bill? I don't see you here.
Well, I'm just right here. And so I want to thank you, Eva, for scheduling this meeting. We've had 35 people online. Brian, that was an outstanding report for our community, and I just want to personally thank you very, very much. This is a free Zoom account that we've been using for this, and so we're going to get cut off in just a couple of minutes. Eva, if you had any closing comments.
Well, next week we're going to have Dr. Kent Sharman, who is the spokesperson for North Bend Medical Center, speak. He's the medical director there, and he will tell us what North Bend Medical Center will do should this come upon us. And again, thank you, Brian. If anybody else has any questions that they want to send to Brian, send them to me and I'll filter them out to him.
Yeah,
Brian?
I guess Eva, maybe one thing I would say is that we have recorded this.
Yes,
And
right.
so I'll send that to you and you can distribute it as appropriate.
Yes.
Bill, if you could you send that to me so I can put it up on the Facebook page?
That's Stephanie.
I sure will, Stephanie. I couldn't tell if that was you impersonating Mike Chavez or if that was really Mike the Bear.
It was both of us, actually.
Thank you for joining us.
And Rotary has a project coming up that we think is going to pass through on hand sanitizer that Rotarian Carrie Mitchell has devised, and you'll be hearing about that soon. I think that's going to happen. So, hey, thank you all. Maybe we'll see you next week. Is that it? Okay.
Thank you.
Bye.
Bye-bye, everyone.
Bye.